Welcome students, welcome to this series of presentation on health economics. Health economics is an applied branch of economics and its history is not very old. So we shall look into the emergence of health economics and how the subject is understood in terms of microeconomics and macroeconomics, and a part of it is on development economics, part of it touches on public finance as well. As always, I like to introduce to you the subject by seeing the context. Now, the context, I would put it with Alfred Marshall's Principles of Economics 1938 quote, where he says, "We have next to consider the conditions on which depend health and strength, physical, mental, and moral. They are the basis of industrial efficiency, on which the production of material wealth depends." So it is quite obvious that if we want to have an industrial efficient economy, we need to have healthy people. And this health is not only physical health, it includes mental health and moral health. So all three together make a healthy industrial workforce. The other two interesting quotes that I use is that one of Winslow, where he talks about the vicious circle between poverty and ill health. So men and women were sick because they were poor. They became poorer because they were sick, and sicker because they were poorer. So whether it is poverty that causes sickness or sickness that causes poverty, there is definitely a vicious circle between the two. And as students of development economics, now or later you will understand this causation between one to the other. The second one that I'm reading out is from Gunnar Myrdal's 1957 economic theory of underdeveloped region, where he says the success of health program will depend entirely on whether they are appropriately integrated in a program of general economic development. So health program cannot be studied in isolation. It has to fit into the larger story of economic development of a nation. Selma Mushkin's article 1958 towards the definition of health has been one of the first papers that I used when I was teaching health economics. She was a professor at Georgetown University, later at George Washington University, and was with the Johns Hopkins University School of Hygiene and Public Health. Since she had her role to play both as an economist and as an administrator, we find her understanding of health with her understanding of health, we can raise several issues that student of health economics would like to answer. The first strand of her thought relates to the scientific advances that took place during the 1900s. So it was a world war. Besides the world war, there were a lot of inventions and discoveries that took place both in the understanding of human body and the ways to treat the sick. I've read through the various advances, and it is both fascinating and intriguing that so many changes took place during that particular period. Though it is beyond the scope of my presentation, nor is it within the scope of my knowledge to explain those kind of advances. But what we are interested is what happened to the health of people once these advances were made in medicine, and what was the cost of these advances. That is an area of the discipline of economics, and we shall examine those areas. So when these inventions and discoveries and techniques that were used in medical care changed, this resulted in increase in the cost of production. So this increased cost of production had its effect elsewhere. What happened with that was it stimulated prepayment arrangements. Medical health care was getting costlier, and there was a need for arrangements to make up for this cost of rising medical expenses. So this resulted in further in altered methods of paying arrangements. So governments were involved, non-profit organizations were involved, related individuals were involved, and private sector was involved, along with the emergence of insurance in health. So this changes that took place during and after the World War resulted in increased cost of production of medical services. It also resulted in the variations and shift in demand. By demand in economics, we mean the quantity demanded at a price. When the prices are high, the demand is low, and when the prices fall, the demand is high. It also means that the variations in demand, that means the changes started taking place in demand, even though the price was increasing, it meant that more people were seeking medical help because people believed that medical health was necessary for them to get out of the situation that they were in. This shift in demand, this increased quantity of health demanded was not only because of the price, but it was because of the intervention of the parties, the third parties who were available to fund increased demand for health. What was the other consequence of that particular observation? We find that what was the effect of this third party or alternative methods of payment and compensation on the price of health services? So, health services would also mean the doctors, the allied professionals who were attending to that. What happened to their charges for providing these services? The related question that comes from that she raised was what happens to the capacity of the system to produce health? In economics, when we use the word capacity, plant capacity, we mean what is the production capacity of a machine or of a factory. Here, using the term in that sense, it meant that what happens to the number of hospitals, nursing homes, equipments, and all those doctors and nurses, all those facilities, whether they have to increase to match this increased demand for health. So, this health, the provision of health services, not only required just that increase in medicine and increase in the payment, but it also demanded an increase in the production of the capacity that could provide health to people. Let's look at investing in health. In economics, we use four factors of production to say production takes place: land, labor, capital, and organization. Capital is the produced means of production. Tools, equipments, buildings, infrastructure is known as capital. But in the 50s, late 50s, and early 60s, we find that human beings were treated as capital. Why were human beings treated as capital? The the individual required education and training. This education and training required finances or capital. So, once this capital has been invested in an individual to develop his skills and also to improve the knowledge of a person, then that person is more valuable than a person in whom these investments have not been made. Thus, this term human capital arises, and Theodore Schultz gets the Nobel Prize for that. So here we find that after making investment in human being, the next question is, what is the yield of investment in health? If we invest in health itself, if a person is sick and we invest in health, what is going to be the return of that health? What is going to be the net investment? That is, what is the next yield of that kind of investment in health? So, as an economist, you would understand that if there is no return, how would it happen in the case of other goods? But in the case of health, it is not the same. So, how does health as a capital investment in people behave? The other question that arises for us is, what is the relative amount of supporting capital investment that is required? Is it just enough that we have more doctors and nurses and technicians, all of them being trained and becoming human capital in the field of medical sciences, or does it require the supporting capital in other areas? So, which means it does it require research? Does it require development? Does it require the other facilities that are associated with medical health? So, is it just that we can increase the doctors and nurses that we would get better health, or do we need to improve all other services? So, what is that capital that was required for other activities? What are the effects of changes in health status? So, once we invest in health in a person, his health status would improve, because obviously it is a sick person who is requiring investment in health. So, this investment in health of a sick person can increase or change the monetary value of his or her productive capacity. So, a healthy person's productive capacities are different from that of an unhealthy or sick person. So, here the question is, when we make investment in a person in terms of medical health, then what will happen to that person's productive capacities? There's another way to look at this relative amount of supporting capital requirement. Is it just that doctor services would improve the quality of health of a person, or is it that the person would also require better water, sanitation, food, all better housing? All of these are also required to improve the investment in health. So, investment in health is a very broad area. On one hand, we are talking about investment in the professional part of providing health, and on the other hand is the investment that is needed in regaining health of the consumer. So this itself is a huge area of economics, and research can be done in any of these areas. The second important area that Selma looked into or raised an issue was her interest in life expectancy. Her question was, is it possible that by providing health inputs to people, will it increase the life expectancy of people? She found that in those less developed countries, the life expectancy was very low. It was as low as 30, whereas in other countries, it was as high as 70. So her question was, without spending much money, without making much changes in the expenditure, with minimum interferences, can it happen that we can reduce the mortality and morbidity of nations? Can nations live better if they make small changes in the way they treat health? Then her examples are that of spraying DDT those days, and those days the BCG vaccination was already available. And with these kind of intervention, the quinine for curing malaria was available. With these kind of interventions that she saw, that the number of deaths had reduced in the less developed countries, and as there was treatment available with penicillin, there was dramatic results in by seeing the reduced mortality from malaria, from tuberculosis, and from syphilis. So these were the observations she made about the macroeconomic aspect of health, which affects the nation itself. The other question that was from there we can ask is, what is the effect of investing in the health and on the economic growth of a nation? Does an economy produce more? Does it become more productive if its investment in health is good? All these raise economic issues. What is the economic issue? We know that economic resources are limited, and resources have got alternative uses. So the scarce available resources have to be very judiciously spent between alternative uses. So here what we find is the resources that are available for providing health to people in a country is also a challenge, because poor nations also do not have much resources, but at the same time, providing resources for health is necessary for promoting health and productivity of the nation. So it's only then that the population becomes healthy, and only when the population becomes healthy do we find that the nation is growing well in its GDP as well. Let's look at the term market for services. When we use the term market in economics, we mean the interaction between the suppliers and the consumers, the producers and consumers. They interact in such a way that they arrive at what is the right price at which the consumer would buy, and the right price at which the seller would be willing to sell. Now, this market functions in an uncoordinated manner, in some sense an automatic manner, because the producer is interested in maximizing his profit and the consumer is interested in maximizing his utility from the expenditure that he or she has made. So these are the two opposite forces, and both these opposite forces are rational, and they want to increase the benefit that they get from their actions. Now, the question that we ask in health economics is it that profit is the only motive that will drive economic activities in health? Therefore, to us now we know that profit motive is not the only explanation that can explain why we need to make investments in health. The other one is hospital care is either primarily provided by individuals as clinics, or by public government hospitals, or under non-profit bodies and institutions, and today, of course, by corporate sector. So there are a variety of organizations that provide health to individuals. Now, physicians, let us see what we understand of physicians then and now. Physicians accepted their social responsibility in that sense, and many times they also did not provide their knowledge and skill with a sick person for remuneration. They would also do it for the sake that somebody is sick and they could cure that person. Then we also find that the medical practitioners evaluate their leisure, work, and income quite differently from the way an industrial worker views his leisure, income, and work. So there is a difference in the way the practitioners of medical care do with their work. Definitely, today the situation is different. There is more of professionalization of the work, and therefore these terms have got a different connotation in today's corporate medical care. Now, where the price is the sole means by which demand and supply of medical health services can be equated. So, if the price is low, does it mean that the sick person will get poor quality of health, or the price is such that he cannot access that health? So, to us today, it raises the issue of accessibility to health, which has become an important part of public policy relating to health. Health is also related to social responsibility. So, is it correct that a large number of people are sick in the country? So, what is the social responsibility of curing the sick people? In today's world, we know that we are all facing the pandemic now. During this pandemic, is it right to leave a large number of people sick unattended because they don't have access to hospitals which charge them very high? So, what is the social responsibility, and who takes care of that social responsibility of providing for the sick? So, these are issues that have emerged in terms of the medical services that need to be provided. It was also seen that many practitioners of medicine would treat their patients even at very less payment, simply because they knew that the patient could not have paid. So, and they would charge the other patients who could pay a little more, an extra from them, so that they could cover up their expenses. So there was these doctors and professionals had the ability to roughly evaluate the ability to pay. And this ability to pay principle, even today, is used For example, in the current vaccination drive, we can see how the government has left a portion of the vaccination in the open market to give it to those people who have the ability to pay, and a large amount of the vaccine which is left to the government or to the free sector, so that those who do not pay and cannot pay also get their vaccination done. So there is this kind of a social responsibility in providing healthcare to people. Today, individuals, though today the professions of doctors is far more individualized as well as corporatized today than it was earlier, with a variety of specialization, and the world of medicine has become very, very competitive in terms of the supply of medical care. Let's look at medical care as a commodity. In economics, when we talk about a commodity, a book, a pencil, a bottle of juice, or something like that, we mean that these commodities satisfy a need in us. So, when commodities satisfy a need in us, we are willing to pay price for it. Now, these commodities have one peculiar nature, that these commodities are also exchangeable. That means if I had a bottle of juice with me and I would not want, though I purchased it and I do not feel the need to drink it, I could always exchange it with somebody else or with the shopkeeper again and get something in instead. Now, the question is whether in the case of healthcare, this exchangeability is possible. It is not possible because the suffering of health is done by is gone through only by that individual, and medical care can only be given to that particular individual. So medical care is non-transferable in that sense. The other thing is that these medical care, there is it is not a homogeneous commodity that we are talking about. There is a wide variety of medical services that are required, and therefore there is no homogeneity in the services required and also the services provided, because the services provided differ according to the doctor's knowledge, ability, skill, and the experience of the professional who is providing that. Whereas a bottle of juice of a particular brand would be the same across the entire bottles because they are homogeneous in nature. That does not happen in the case of medical care. So the same treatment could be different by other doctors, the prescription of medicine by different doctors could be different, and the treatment in different hospitals could be different. So there is no homogeneity in the commodity that is health as a service. More so, the needs of the patients are also different. So each patient has got a peculiar need of health, and therefore they have to be taken care of in a different manner. So all these things complicate the market for health, the commodity which is medical commodity which is health, and therefore we need to understand medical care as a separate subject to understand how can we use the principles of economics to analyze the health behavior of individuals and of nations. And these medical services are considered as personal services. They were considered as personal services, and commercialization was not a character of that field. That means the relationship is established between a doctor and the patient. It has not moved much from that. Even today, we know that we are talking about an association with a known doctor or a nurse or a hospital. But in this highly corporatized world, again, there are issues that have emerged in this commercialization of medical care. Now, how do consumers behave in this medical care sector? Consumers do not choose between health services and other goods as rational choices. In economics, we believe that consumers are rational and they think what is best for themselves. They are logical in their thinking and they know how to choose between two commodities. Now, and that is how they make decisions. Now, can we apply that same reasoning or the same rationality in the choice of medical services? Consumers' outlays are primarily undertaken to cure or provide services to the sick member in the family. So, if a member of the family is sick, then other choices that a person has in the family, for example, buying some durable good, may be forsaken at that time when the other person is sick and has to be taken care of. So within the health sector, there can be choices that are made, but as a family income, the rational choices are here to save a sick person or to help a sick person get better. So, to that extent, again, we find the rationality may not be the only reason why people make choices in healthcare. Another important area that has come out from this understanding of the changes in health and healthcare is what happens to consumers. Are consumers completely aware of their health condition? Do they know what is the quantity of health intervention they require? Do they know what is the quality of health services that they require, and what is the price they are going to pay? So, consumers in healthcare often suffer from lack of knowledge, or we say asymmetrical information, a topic that I shall do it in course of time. So here we say consumers experience absence of knowledge about the quantity and quality of health services that they require, in which case they have to depend entirely on the medical professionals who are taking care of them. Independent markets, whether healthcare is just one unified market or is it a mix of several kinds of market. So we now know that healthcare is not a unified market. It has got several independent yet interdependent market. Education, training, skill of medical professional, that is a sector by itself, where the medical education, the nursing education, dental education, and several other kind of education that are needed to prepare the personnel providing medical services. So that is a market by itself. Who demands that kind of education, who provides them, and what happens to the investment and cost of such kind of education. The other area is institutional markets, where we study about setting up of hospitals and clinics and nursing homes, and also the individual charges that doctors may in the clinics they may charge for the services that they render. So how do these work? Do they work independently, or are these are also there is an intervention in this working by the government? We also have the pharmaceutical prices, the medicines that we purchase, the variety of medicines that we purchase, the equipments and the others that we may use during healthcare, and also the diagnostic methods that doctors may suggest for identifying diseases. All of this is another market. So there are many allied sectors in this medical care industry, and all of them together form what is called as health economics on one hand. Of course, the other end of health economics is the side of how it affects the general health of a nation, what happens to its productivity, and how do nations grow when they are healthy. Remember, in the case of Human Development Index, longevity itself is taken as an indicator, and longevity depends not only on the food that we take, but it also depends upon the food and the water, the sanitation we take, but also depends upon the general health of the people. When all of these are combined, we talk about it as health economics. So what I would do is I'll present a series of presentations touching upon one on the other, and you will get a fairly good idea about health economics. Thank you very much.